Hello, happy Wednesday, everybody. I am Farrar Duro, and we are starting our Instagram Q&A, fertility Q&A with Dr. Kenneth Gelman tonight. And I encourage you to continue to send us your questions. We actually have a lot of questions, so this is going to be exciting. We have plenty to talk about tonight. And actually, I see Dr. Gelman popping in and invite him over. Let's see if I can see if he pops
Hello.
up. There he is. Hello. How are you?
How's everybody?
This is a really great time for Q&A. It's kind of rainy and one of those days. And
Oh,
so
it's a great night for that. Every night's great, but this is a great night.
it'd be awesome. Yeah. And we have so many questions. Let me just make sure I check my volume here. And I made it here on time, which I was excited about because I almost didn't.
Oh, great. Awesome. Huh?
I was a little stuck, yeah, in the traffic out there, but we're good. We actually have a few questions submitted. I want to introduce you in case anyone's watching and they don't know who you are. If you could just please tell them a little bit about you and where you practice and everything.
I'm Kenneth Gelman. I'm one of the many doctors of IVFMD. Again, I can never remember how many we got. I say that every time. I think there's 11. And I'm in Cooper City. And just very happy to be here and happy to be part of this excellent night.
Awesome, thank you. And we've worked together a long time. My name is Farrar Duro. I'm a licensed acupuncture physician, and I'm in Miami, Hialeah, Broward. We have many different types of treatments that we do, but mostly we focus on reproductive acupuncture and Chinese herbal medicine, and also nutritional approaches as well. We have an awesome massage therapist too, so we've been doing a lot of that as well with our treatments. And we work a lot with women and couples who are trying to prepare for IVF or going through IUI, and also working with natural treatment as well. So, and this is Pride Month, so I want to say we also support the different types of fertility treatments. We also work with a lot of same-sex couples as well, and we want to encourage those questions too. So if you guys want to
All kinds of questions. All comers.
Yeah, so please don't be shy. All right, so we're going to get started because we have a lot of good ones tonight to cover. Our first one is actually the first question is about acupuncture and herbs. So we'll go ahead and it's basically involving, do you do herbs with supplements? Like, is that okay? And I know that different cycles are going to require different things. I know you guys do have supplements that you recommend sometimes to your patients, and typically they're different than what an herbal prescription would be. So they're definitely two different animals. We think of Chinese herbal medicine as a separate practice from nutritional treatment. So it depends on the patient, on what they require. And not all formulas are the same. We customize our blends, so it's a little different for someone who has, for instance, like PCOS and fibroids than somebody who has diminished ovarian reserve, and we call it's very like yin deficient, or they don't have the same amount of makeup as far as hormonal and also diagnostic in Chinese medicine. So those are different types of formulas, and we don't always give them, because if someone's going through IVF, we're not going to give them herbal medicine usually right away. I mean, that's if we have time to work with you. We've been working with you for a few months, and the herbs have time to work, right? So like if somebody is starting IVF right away, I don't think it makes much sense to start herbal treatment, because it's not really going to be enough time, and we don't want to mix the two, especially when you guys are checking your the estrogen levels so closely. We're not sure if the herbs are going to interfere with those numbers, so we typically just hold off. But the supplements you usually continue, depends, I guess, throughout certain medicated cycles. So that question is like, can you do both at the same time? You could, but it all depends also on your practitioner and you guys too, and having your practitioner work with your IVF doctor as well if you're doing a medicated cycle.
Yeah, I mean, we usually, all the supplements and all the things, we like to use that all in anticipation up to starting the cycle. So once they're on the cycle itself, like you mentioned, we don't want them taking all these supplements and things like that, because of the fact they will interfere, especially like, for example, DHEA would be one that, it's a male hormone. We don't want that on board while you're going through a retrieval process or an IUI, whatever it may be. That kind of thing. And then, some of the Chinese herbs, things like that, we probably would suggest they hold off on that while they're going through stimulations and things like that. But all in anticipation up to the starting the cycle. So that's why it's important, that we use acupuncture and things like that as an adjunct, and we start all these things early enough. So
Right.
people start to go, because some people, may not go until the last minute. It's not going to really benefit you. You got to go 2 to 3 months, maybe 6 months, before, preferably 3 months, probably at the minimum.
Yeah, and we do get patients who are in their 40s, mid 40s, and they want a quick solution. I understand, because you think there's, you want to be pregnant yesterday, but there's no miracle treatment, unfortunately. I think, with our treatment, your treatment, it's very difficult to say that 100% it's going to work, and I wish that it was that way.
Exactly.
I wish we had a crystal ball,
Exactly. Exactly.
Yeah.
And then it's a time commitment. These people have so many things they're juggling, and I feel for them, because, we tell them obviously to go to acupuncture 2 to 3 times a week and to schedule that appointment. And then they're coming here for their, their workup or their, whatever they're doing. And they have work, and they have maybe, other responsibilities. So it becomes very difficult. And, you got to applaud people that are going through this.
Yeah.
And that are able to juggle all these things and really be successful at it. And, at the end, when it works, it's just such an amazing thing. And, I'm so proud of the patients, what they've done.
Yeah. You guys are awesome. I think I look at estrogen levels sometimes like, wow, it's like 20 times higher than it would normally be. You guys are doing great, And the spouses too are very supportive. It's a safe.
Yep.
It's a time of that. So we have a question about day 6 blastocysts, 2 were frozen and not biopsied. Chance transfer successful. So so they were not biopsied at day 6. Day 6 blastocysts.
Yeah. Actually, it's pretty good. I mean, our embryologist actually just let us know those statistics, and it averages, depending on the age of the patient and the age of the blastocysts, obviously. But at 35, it's probably a good 50% successful. And down to about 40% after 40, 41, 42. So it's not bad. I mean, just because they weren't biopsied and they are on day 6 doesn't mean they're not going to make a baby. So you should have some encouragement on that. And I was very encouraged, actually, by seeing those statistics. Actually, today, I saw them.
So that's based on day 6 versus day 5?
Yeah, that's day 6. So those are frozen embryo transfers on day 6, frozen.
Okay, and it's 50%.
Yeah, depending on the age, obviously.
Yeah. So that would be versus day 5 would be more successful, you think, or?
Well, yeah. I mean, I think it's higher, but certainly at day 6, you still have the ability for that embryo to divide and implant. I mean, you're talking 50%, and that's ongoing pregnancy rate, actually. 50%.
Oh, that's awesome.
Yeah. So that's pretty good.
Yeah. Oh, that's great. So. And basically it would depend on other details, but it's good. We don't have age or anything there, but it's already frozen, so hopefully that is going to be a great one. And good luck. We're crossing our fingers for you, Bridget. And then we have a question about how long does a frozen sperm, how long does frozen sperm live in the body? So I guess after it's thawed, I would think.
Yeah. Well, we're not putting frozen sperm in there. I mean, obviously it's thawed out, and it would be theoretically as viable as normal sperm if it's a good specimen, obviously. And places like these good donor banks, obviously we get pregnancies all the time, so it functions pretty much like normal sperm does. So, I mean, they say sperm can live, 72 hours, for example, or I think it was reported up to a week to be living. But
Mm-hmm.
theoretically, it depends on the sample, but assuming it's a good sample, it should function just like normal sperm. Sperm freezes very well and thaws out very well for the most part. So, there's usually no real major issues with the frozen sperm that we obtain from FDA approved accredited sperm banks where, many of these guys have already had pregnancies too. So their history, the sperm works.
Yeah, I remember had a patient who was the sperm was frozen 20 years.
Yeah.
That was crazy. And they had a baby, and so I kept thinking, wow, it's like half of you is 20 years old.
Yeah, the sperm, yeah. Yeah, that's absolutely true. Yeah.
So and this is the same person asking, for those trying ICSI with frozen sperm, oh wait, it says, no, ICSI.
Well, I think I saw that question.
Yeah,
that looked like intracervical insemination.
Oh, I see. Okay. Yeah.
I think that question was probably, I would think, somebody who's trying a home insemination. And they're using intracervical insemination.
Oh, is that
which, yeah, that's probably what it is. Which, I see some people do, I guess, but, we don't recommend that. But, I think I would try to cover your window of ovulation as best as you can. And, I don't know what kind of ovulation testing you're doing or whether you're using clomiphene or Femara or any of those things. But, you try to cover your window of ovulation, which, is over a 36-hour period, but I don't know when your specific one is. So it'd be hard to know exactly when to do that, but theoretically you would want to cover that 36-hour period, and that's why we do 2 inseminations normally in the office, but we time the ovulation process by HCG shot. So we know, roughly when the patient is going to be ovulating. So we time it usually at 12 hours and at 36. So we do 2 of them. So assuming that person has 2 vials, maybe they could do 2 of them over that period of time. That would be my suggestions. But, again, it's hard to do at home. And, there's some risks to that too. So, I think that sort of answers your question, but I think that's what they were asking. It's about intracervical insemination. I don't think it didn't sound like ICSI itself.
Okay, that's good. I'm glad you clarified it. And the same person asked about how many IUIs do you usually recommend before pursuing IVF for those under 35?
Yeah, that's a big debate. I mean, I think that depends a lot on the practice you go to, financial issues. Is this unlimited finances? I mean, because things add up if they're not working. How comfortable are you going to IVF? How comfortable are you with that process? Somebody maybe want to do it sooner rather than later, but some places do up to 6 IUIs. Before they switch over. So most places, I would say, us is usually 3, but some people can go up to 6. I've had people do 7 and 8, and it works on the 7th or the 8th one.
Oh wow!
And yeah, and you always wonder why didn't it work the first, the second, the third time.
You need a crystal ball.
You don't. Yeah, you don't. You're not going to know with IUIs, and people always ask me, well, why doesn't it work? They have a perfect ovulation. Perfect, young person under 35, for example, perfect tubes, excellent sperm on their semen analysis, it doesn't work. I mean, that's just the nature of this beast. It's just not a perfect system. And statistics of IUI, if you look at it, aren't great. I mean, they increase after 3 attempts or so, but, the statistics are still nowhere near what IVF can approach. And it's just the way it is. But there are people where it works the first time. I mean, and that's a great thing. But, most times it does not.
Yeah, and are you noticing it works better for people with male factor issues or less for that? Or?
Well, I wouldn't pursue a lot of IUIs with male factor. You have to have at least 5 to 10 million total motile sperm after the wash procedure with an IUI.
Okay.
You know, so if you're sort of out of that realm, if you're a lot lower than that, I mean, not that it couldn't work. I mean, I never say never because I've seen it work on occasion with somebody pretty low.
Mhm.
You know, but I wouldn't invest a lot of effort into that going further if that's the case. I would, you know, step it up a notch and go to IVF because you know you're working against the odds, really.
Yeah. Yeah, I would think it would be great for someone who has maybe some cervical issues too, where it's just easier, like mechanically, I can with the sperm
Well,
ready to go.
I
So
mean, I mean, you know, then a lot of people do, you know, maybe try IUIs because you know they've been trying on their own, and you know it gets very stressful with timing, and you know the husbands get freaked out a little bit sometimes, and you know it gets a little tough, and sometimes it's better when the doctor does it. You know, kind of takes a lot of the stress away.
hmm especially scheduling and all those things, it's
Yeah,
difficult.
yeah,
And now we have another question about can embryo quality change? Our doc told us that an embryo was 6 cc and later became a 6 bb.
yeah. Oh yeah, and I tell people that all the time. Don't get hung up on your score there because that's one shot in time. That's when the embryologist looks at the embryo, you know, right before they freeze it, essentially, and then
Okay.
um, when they unthaw it, ready to transfer it, you know, they have to thaw it out a couple hours before, and it'll change. It'll improve. It'll expand. So that's not unusual for you know a BC to become a BB or a BB to become an AB or you know something like that, where it really looks great by the time you transfer it. You know, we hand the picture to the patient, you know, right before transfer, and you know the thing's expanded and hatching, and you know really looks great. So it definitely can change. It's a dynamic process. It's not just a stagnant embryo. This changing all the time, and you know that's one of the things actually they look at in the lab. They have a time lapse photography on the embryos. They can actually watch them grow 24/7. No, so somebody doesn't have to actually take the dish out and look at these embryos. They have them under an actual camera.
That's so cool.
So they have the patients can actually see those pictures.
I was reading that some embryos can self-heal or something, like where they'll actually do a biopsy, they'll look at it, they'll say something, and then they go back in to do another biopsy, and the genetic thing's not there. So, I mean, that's pretty cool. Like, they're just finding out all these different things about these little guys. And
Yeah, the embryos, you know, they discard things, you know, as they're kind of developing. They discard.
yeah.
And then, you know, I mean, well, you're talking about biopsies. I mean, depends where they biopsy the embryo. It's
Mhm.
not uniform. That's one of the problems with PGT. You know, it's not uniform among all places around the world. So, you know, one embryologist may do things a little bit different than another one, as far as where they biopsy the embryos or how they do it.
We should have an embryologist on here for our
We should.
clinics. All right, guys, like, give us a
Yeah,
thumbs up. I'm going to talk to the embryologist. That would be so much fun.
yeah.
Why
I
we've never
think I
done that.
will. I think we should.
Yeah, Sylvie. Or anyway,
Sylvie,
that would be,
Sylvie,
yeah.
where are you, Sylvie?
Come on. Okay, so we do have a question about lining, and this one came in earlier. If S-trace does not thicken the uterine lining, what other options are there aside from increasing the dosage? Also, does it make sense to take Provera with a lining thickness of 3 millimeters?
No, absolutely not. Um, that's a problem. I mean, that is a problem we see every now and then. Yes, we try increasing the dose. We try a lot of things. And sometimes we're successful, sometimes we're not. I mean, there's a lot of anecdotal things out there, like there was reports about Viagra suppositories. You know, that's not really been established. Maybe a couple of people have responded with it, but most people don't. But we try them. We try Neupogen infusions, and I've had some success with that over a period of time where we can actually thicken the lining slightly. It causes these growth factors to be secreted in the lining. But that's an issue in some people, and that could be a very difficult problem to overcome. Um, and that's, something where I've had this situation before where I had somebody barely had an aligning of 6, trying everything. And I decided to do an ERA test, and actually, it turns out they were just mainly pre-receptive. So they had enough of an estrogen effect there to induce enough things to go on that once we started the progesterone, they just needed extra day of progesterone, and we adjusted that and we transferred her with a lining of 6. She got pregnant.
Oh, nice. Okay. Yeah,
So, it doesn't always mean anything, but certainly a lining of 3 is a real problem.
Yeah.
And you got to look for potential reasons for that.
Yeah, I mean, there's some research about acupuncture being helpful, and we've seen that sometimes a little combination approach for blood flow. Maybe there's some, other factors going on, stress, things like that, and also over exercise is not great, but like if they're doing too much.
Yeah, well, also sometimes what happens is that the preparations that we use, like if this is a prepared cycle, using the medications that we give them, estrogen, progesterone, they also are on Lupron. And Lupron decreases a lot of blood flow to the uterine arteries. It thins things out. That's what we use it for, so people don't ovulate. But that might be affecting this particular person. So if that person is on Lupron, obviously I would stop that cycle, not start any progesterone, and I would consider, if they are, have regular cycles, maybe just doing a natural cycle transfer. Maybe they do much better on their own, and their lining thickens beautifully on their own without us really doing anything. Maybe we can window dress it a little bit, but don't use any Lupron. Because and then give that patient an HCG shot when they're ready to ovulate and transfer the embryo.
Very neat, awesome. So hopefully that was helpful. And lining can be stressful. That lining, everyone's worried, like, is it thick enough?
Oh yeah. But that's something I would definitely do in that person, is try a natural cycle.
There is a question also that came earlier about the person says that they're prone to yeast infections. Can this affect me getting pregnant through intercourse? For example, does the infection prevent the sperm from fertilizing my egg, or does the infection affect the pH of the sperm? Hope this makes sense. Also, does having a yeast infection at the time of frozen transfer affect the outcome of the transfer?
It may. I would certainly make sure you don't have those kinds of things, because it is going to affect, potentially what happens, certainly during natural intercourse, most likely. Any infections, but like vaginosis, things like that. And you don't want to have an active yeast infection at the time of your transfer. I would say that's got to be, addressed. So, talk to your coordinators about all that and make sure it's addressed before you get transferred.
Okay, and then actually I just noticed I skipped a question in the chat, so I'm going to go back to it. Do you recommend IUI on someone with Hashimoto's and low AMH?
Well, it depends on the age. Again, depends on the age of the person. A young female, if the female is young, I would certainly, and I've mentioned this before, is the AMH accurate? There's too many occasions where people come in and their AMH is not accurate, and their antral follicles are plenty, and they're ovulating regularly, they have a regular cycle, so the AMH doesn't make a lot of sense. So in that person, if she's young and we think she's ovulating and she's got a good reserve, we think definitely I would try it. With Hashimoto's, absolutely. I mean, not everybody with Hashimoto's disease is going to miscarry or get, there are a billion women out there with thyroid disease and, thyroid antibodies. Not everybody miscarries. It doesn't mean you're going to miscarry. But I would certainly look at those levels and consider, maybe that person, obviously make sure that TSH is low enough on Synthroid, and maybe put them on a little steroid like dexamethasone during their ovulation cycle and keep them on it to reduce that as antibodies, and or If the person's really concerned or if they've had miscarriages, I'd be looking at, natural killer cell activation. And if the person's not getting pregnant, maybe they have endometriosis also, because that tends to go hand in hand a lot of times with thyroid disease. They're both autoimmune diseases. So we tend to see that, occurring together.
Yeah,
So,
there's thyroid issues, they're major. I mean, I just feel like
major.
so many people have thyroid issues. So
it's very common. It's very common. But, if the AMH is low, I mean, again, depending on the age of the patient, and there are some young people really who do have a low reserve, that's got to be assessed with an ultrasound too. So I would not just, assume you got a low AMH and never have an ultrasound. Nobody's ever really verified that.
Mm-hmm.
So what I'm saying is verify that you really have a low reserve. Look at your age and, and make a decision, because if your AMH is really low, I'd be aggressive. I wouldn't do IUI. I'd go to IVF. But if it's really just an abnormality that's wrong and you really have a good reserve, I would try IUI, especially if you've got, obviously normal tubes and normal sperm function, et cetera, et cetera. And then maybe address the autoimmune part, by looking at other things to see, hey, have you had a miscarriage before? That kind of thing. And look at your immune system and possibly address that in addition.
Okay, great. Yeah, and it's just something that's not checked. Those antibodies aren't checked a lot of times. They'll just do like.
Well, we do. I mean, anybody that comes in,
Yeah.
they're gonna get a pre-pregnancy panel of which thyroid antibodies is a part of it. I mean, that's like, looking at your FSH or your AMH, you're gonna get thyroid antibodies, and you're gonna get a thyroid profile. You're gonna get all that. That's what you need to look at. So your doctor needs to review all those things, discuss those with you, and if you don't know what they are, ask your doctor. How's my thyroid function? Do I have thyroid antibodies? Do I have, good AMH? Is my AMH in the right range? Is it accurate? Do you think it's accurate?
What is the level of antibodies that you're comfortable with, and then you start to become uncomfortable when you see them?
Well, I see some low ones sometimes. I mean, I see some of 25, 15, 20, 25. I don't really worry too much about them, but on the other hand, I see people in the thousands, real high elevations, and that's a significant amount of autoimmunity going on there. And the antibodies just are a sign of autoimmunity. That doesn't mean those antibodies are floating around attacking pregnancies. Those are just a sign of the inflammation that's going on in your thyroid. Presumably will cause, thyroid hypofunction at some point, or underfunctioning of the thyroid at some point in that patient if they don't have it already. But it's also an indicator of other autoimmunity going on there. About 20% of people, they say, I think, will miscarry with thyroid disease. So you got to look for other things. I mean, you got to look for, and there are other autoimmune diseases that go along with thyroid disease besides endometriosis. Not that we're all looking for those things, but type 1 diabetes and, parathyroid disease, things like that. So autoimmune diseases can run together, and they can run in families. So it's pretty common that they run in families. So somebody has it, you inevitably you find out that their mother had thyroid disease, or their sister has it, or somebody has type 1 diabetes or something like that.
So it's super important to get that checked for sure. And it's treatable. I mean, well, the Synthroid, you'll expect the levels to get a little lower, but it's still.
Yeah, I mean, the Synthroid is not going to necessarily treat the antibody problem. It's not going to, and some people, think it really makes a difference in terms of miscarriages, things like that. But there are some evidence that keeping the thyroid levels, TSH under 2.5, can affect several things, including intelligence of the offspring. But I think it does improve the ability not to miscarry. That's my personal observation, I think. So I think putting people on Synthroid is a good idea. And I think, trying to treat the antibodies depending on how high we think they are and what their history is, trying to lower them as much as we can. There's some anecdotal stuff about selenium, being helpful in some patients. So, 250 micrograms, I think, of selenium might lower it in some people. It's a vitamin. And or dexamethasone.
So again, dealing with inflammation too, because it can kind of go
Yeah.
everywhere.
Yeah.
So we have some other questions just popping up, and we're trying to get as many questions as possible tonight. So we're gonna, but I don't know if we can finish all of them. But we're gonna try. So we have another question. Basically, what is the maximum amount of time I should be on birth control prior to starting a frozen embryo transfer with donor eggs?
That's not going to matter, because your ovaries are really out of the equation at this point. You have donor embryos, it sounds like, right? Donor eggs, donor embryos?
Donor egg, yes, with partner sperm. Yeah.
Yeah. So doesn't matter. You could stay on it as long as you want, whenever you want to have that transfer, because your ovaries really aren't part of this equation, and the uterine lining will have to be prepped with estrogen and progesterone, which the nurses will do for you. So they'll take you off birth control pills, they'll put you on the proper medications and things, and will prepare your uterus, because your uterus is the one that's going to receive the embryo, and your ovaries really are not really part of the equation anymore. So it doesn't matter if you're staying on birth control pills.
Yeah. Very good. And then we have a question here. I'm 28, endometriosis, and haven't been able to get any blastocysts. I have 3 IVF cycles. I'm feeling discouraged. Is there something I can do to help?
Oh, it's a tough case. She's 28 and has endometriosis. Yeah, that's a tough case. I probably would be looking at the amount of endometriosis treatment you've had. Did you have surgery? To clean some of that up? And or did you take Lupron to try to suppress it and try to reduce the amount of inflammation going on in there? Because it's an inflammation disease. It's probably affecting your eggs. So I would make sure your endometriosis is very quiescent as best as possible. Maybe some surgery in this case. Might be benefit to actually debulk it, take it out of there, not cauterize it, debulk it, take it out, remove it, and then go on Lupron for a few months, like the old days, so to speak. Make sure your CA-125 is nice and low. Go on a gluten-free diet, high doses of fish oils, things like that, and see if that improves things. But that's a tough case.
Yeah, definitely. We help with, we use Chinese herbs as well for endometriosis.
Yeah.
Time, because we find it does help with the anticoagulation, to help anticoagulate a little bit. So if there's clotting, pain, cramping, that sort of thing, it's nice to do acupuncture too, if you can do that for a few, at least a few months. If you are planning to do another IVF cycle. But that is frustrating, and our heart goes out to you, because you're going through all that and still not getting any blastocysts. That's just really frustrating. So
that's got to be that's a tough case. That's got to be looked at in more comprehensive fashion, and look back and see what was done and what kind of treatment this person's had, and see if we can readdress that and improve upon that.
Yes, and if maybe that is about time to get a second opinion. Perhaps like after cycles, if things have not changed, like it doesn't hurt to have another set of eyes.
Absolutely.
I would say
Absolutely.
Look at everything, and
Absolutely.
And now let's see, we are going to jump back into our questions submitted earlier. So let me see if I can flip through there. Okay, if TSH is high, 5.9, fertility treatments. Oh, can fertility treatments fail? You probably wouldn't start anybody on any fertility treatments if the TSH was that high, right?
It's not terribly high. The regular doctors probably would be debating whether they even treat you with TSH that high. There's some debate about even treating it. But in our field, yes, I would definitely treat that. And certainly if we picked it up, obviously, before you were starting anything with your your pre-pregnancy panel, yeah, you would be on treatment before you even started anything. So we wouldn't, bat an eyelash at that. So that person would definitely be on thyroid pills.
Yeah.
Um,
Yeah. And it takes sometimes a month or two to lower it down, right? I
yeah,
mean,
yeah, it takes, I mean, theoretically, one half like a month or so, 3 weeks, 3 to 4 weeks to check that. I mean, that little bit of an elevation will come down very quickly. But, thyroid pills, you got to be careful how you take them, because it's a very poorly absorbed medication. So you got to make sure you take it on a very empty stomach. And there are people who don't, necessarily comply with that. And they come back, their levels are still high. Well, they're not absorbing the pill. So you have to be very careful with that. Thyroid pills have to be taken on a very empty stomach.
yeah, I definitely, sometimes people are not told that. And they're like, what? I've been taking this for like a year. It's not
Yep.
working. Now I know.
Yep.
We have a question here about one miscarriage, 35 years old with low AMH. I guess it says FSG and fibroids. Any hope for me? Is that
Sure.
low FSH maybe? Oh,
Yeah, FSH, yeah.
okay.
Well, I don't know about low FSG. I don't know what that is.
I'm not
But
sure.
but low AMH and fibroids, absolutely, there's hope for you. But you probably will need IVF.
Just saying.
And or is your fibroid a problem? Just because you have a fibroids are all about location and size. Location. So if they're sitting, right in the middle of the uterine cavity, yeah, they're coming out before you get a transfer. But with something like that, I would recruit your eggs, do a retrieval, make embryos, maybe PGT with them or not, freeze them, and then readdress your fibroid issue as to whether that needs to be removed before a frozen transfer. So there's definitely hope.
Yeah, for sure. And I hate hearing about miscarriages. We all hate miscarriages. We wish they were
Yeah,
there.
because the PGT maybe will help things, maybe not. But you gotta assume that the more common things are common, that chromosomal issues are most likely to cause. But maybe a recurrent pregnancy loss evaluation, make sure there's no clotting issues, maybe checking the immune system, basic things. In addition to doing PGT, and or maybe embryo banking, maybe because the AMH is low, maybe several cycles of retrievals, 2, 3 cycles, some people do. And they try to accumulate embryos with low AMHs.
Yeah, don't give up. Don't give
No,
up.
absolutely not.
Okay, awesome. And then we've got a few more questions popping in here. What type of blood test do you recommend before an FET after having a baby a year ago from FET?
What type of blood test do you recommend before FET?
After having maybe she wants to do another frozen transfer.
Yeah, I mean you'll get the standard evaluation that you'll need is you'll need all your hormones rechecked, the pre-pregnancy panel, thyroid, all your hormones. You need to be checking obviously HIV, hepatitis, those sorts of things, CBC, making sure everything is healthy, vitamin D levels, all that. And then basically an SIS, saline infusion to make sure your uterine cavity is normal inside, there's no polyps, fibroids, etc. And a biopsy, endometrial biopsy, making sure there's no inflammation inside there. And that would be it.
Okay, awesome. And we'll jump back into our previously submitted questions here. There is waiting 4 to 5 months to do acupuncture, taking supplements, etc. before IVF. Okay, felt rushed by DOR. Oh, diminished ovarian reserve, perhaps that she has. So she's asking, I guess, is 4 to 5 months. I mean, in the scheme of things, I think you're not going to lose, those follicles in 4 to 5 months, even though there might be this diminished ovarian reserve. What is your take on?
Well, depends how diminished it is. I mean, again, depends on the age of the patient and, that kind of thing. I mean, it might be a little slightly long. Maybe 3 months is probably reasonable. But I'd be really aggressive in those 3 months. I wouldn't waste the time.
Yeah.
So those 3 months really have to be dedicated to you. And I would definitely do acupuncture 2 to 3 times a week. I would definitely do DOR supplements, all the ones that, we would recommend to you. I would, encourage a very healthy diet, obviously, like we've talked about 100 times here.
Yeah.
Stress reduction with yoga, etc. But, I would spend a lot of effort trying to improve things, not go on birth control pills, and use other methods to, help improve your antral follicles, and maybe think about, a couple of retrievals also, just like the previous question. But those 3 months really have to be, aggressive and not wasting time, because if you're not going to do all those things, you're probably not going to do great. You need those things to help.
Yeah, no, definitely. If you have that, low ovarian reserve, it's good to just take action and not to spin your wheels.
Yeah, and it's nothing you did. I mean, that's biology, and some people have that, and we're never going to know why. Make sure you don't use microwave and plastic. Avoid things that potentially are toxins. It's never, you're never going to know what caused it, for sure. But try to avoid the things that we know could contribute, and try to improve things as much as you can. I know it's a lot of work. Like I said before, it's a lot of work.
Yeah.
But,
Partnership.
anecdotally, these things help.
Very good. And we have a question here. Egg fertilization doesn't survive IVF. Is it just because of egg quality or sperm too?
What was that? I didn't hear it.
I guess egg fertilization doesn't survive IVF. I guess the embryos are not growing. Is it because of the egg or the sperm?
Hard to know. I mean, it's hard to know. Again, you got to know the age of the patient, what her history is, things like that. Is there severe endometriosis, like that other question? It's hard to know, but the sperm could contribute in certain cases. Certainly after fertilization occurs, after the 3rd day or so, if, the embryo, the sperm male genome turns on, things like that. So sperm factors there may be causing some of this. But it's hard to know for sure. We have to look at the whole picture.
And we have, do you have a team that guides you in the donor selection process at IVFMD?
We do. We have a whole third-party team, and you get assigned your own coordinator, nurse coordinator, and they will assist you throughout the whole process. They're not going to select your donor, but they'll, guide you to the proper places to find, I assume it's egg donation, frozen egg banks, for example. We work with several. So you'll be assisted in terms of where you need to look and start to look for the proper donor for you. But we don't actually select your donor. That's all coming from you. And we just know anonymously what that donor is medically, what their AMH was when they donated, how many eggs they got, when they were frozen, and have they had successes already.
Definitely. So I realize we're like in the 12-minute mark here, so we have a few more questions to get to as well. So I want to make sure that we try to address them. These are good questions, so thank you guys for submitting them. Is it possible to have an LH surgeon actually not ovulate? If so, how can I know?
There are some situations called a luteinized unruptured follicle. So there are some situations like that, and even in IVF after HCG, when they go in there and they try to get eggs, with the retrieval needle, sometimes the eggs don't come out. They're stuck. Or the follicles don't contain eggs, So you're not going to know on your own, So, and that's one of the things about, for example, when we do IUI cycles, we're assuming they're ovulating, that they're getting the HCG. We detect it in the blood. You can do, pregnancy tests. You see that they got HCG, yeah, and you assume that, if you look at the follicle, it's collapsed. Well, you're assuming the follicle collapsed and the egg released into the tube during an IUI cycle, but you don't really know that. And that maybe that's one of the reasons people aren't successful. Who knows? We don't know. But, in normal situations, you assume all that happens properly.
And the
But,
progesterone, does it give you any,
well, it means that the ovulation process is happening, but does the egg actually release? I mean, the follicle collapses and the corpus luteum is forming, so the progesterone's going up and stuff. But is the egg actually in the tube and just doesn't fertilize, or how do we know? I mean, we don't.
Yeah, if you guys haven't watched the process of ovulation and fertilization, maybe we should post that video. I think it's just fascinating how the little fimbriae, they sweep the little follicle in, it travels up.
Yeah. It really is amazing, actually.
Yeah, I love it. I don't know. I'm just geeky like that, but I like those videos. So you guys should try to Google that. It's really nice to watch that. So how about signs and symptoms of hormonal imbalance? How could it be corrected?
Well, I don't know what you mean by that. I assume PCO, maybe, that you're not ovulating, and maybe you have high hormone levels like what's called androgens, testosterone, androstenedione, or DHEAS. Those are the three. That could be out of balance in some individuals. And, that is something we would treat. We cannot cure, but we would treat it. And there's several ways to try to improve that. If you're overweight, we would get you to lose weight. That may help quite a bit because some of that's due to insulin resistance, and that's improved by weight loss. Metformin may be another drug that may improve things. Testosterone levels may drop on that. And it may improve your cycle and you may ovulate. Not everybody, but some people. And then some people have high DHEAS where, that may or may not be problematic for some people, but other people where we think it is, like it's causing an irregular cycle or acne, we would put them maybe on a low-dose steroid. So, there's ways to address things, to treat them, but there's no ways really to cure any of that. And, when you're doing ovulation cycles or IVF or all that, we sort of work around it. We sort of lower those levels and take them out of the equation so that we can directly ovulate you ourselves and not rely on your body necessarily to do that. We will do that for you.
Yeah, your hormones are definitely manipulated when you get to that point. But birth control is also, a kind of manipulation of there is no ovulation going on.
Yeah, birth control pills is another way to do it.
Mm-hmm.
Yeah.
And speaking of ovulation, we have another ovulation question. Can early ovulation be a concern? I sometimes see an LH surge as early as cycle day 10 or 11. I have PCOS.
Well, 10 or 11, it really isn't terribly early, slightly maybe, but with PCO, are you really ovulating? We always wonder when women come in that say they have PCO. First of all, do you have PCO, or you think you do, or a doctor told you have it and you really don't? Mm-hmm. And if you have a really normal ovulation, if you truly are ovulating on cycle day 10 or 11 and you're getting a positive ovulation kit, and it's not a false positive, which happens with PCO all the time, and you're getting a regular cycle at the end of the month where you're getting, brown followed by red blood, and, it's a real ovulatory bleed, means that you ovulated and you just didn't get pregnant, you're bleeding normally after an ovulation, then you don't have PCOS. Mm-hmm. So, that's a difficult question to answer. But there are people who ovulate early and get, what's called early. Cycle day 10 or 11 really isn't that early. Mm-hmm. the first part of the phase before ovulation can be very variable. It can be longer. So, women with PCOS can ovulate on day 25. And the same question could be, if I ovulate late, is that a bad thing? Well, not always, because people who ovulate late and regularly like that get pregnant.
Yeah, for sure, definitely. I mean, nobody's well, I guess some people are textbook, but we always think everybody's 28-day cycle, but that's not really true. I mean,
No, it can be very variable there.
Okay, so we have a question about baby aspirin. Is it effective in trying to conceive?
Well, we always recommend it. I think it, it increases ovarian blood flow. I think it increases blood flow to the uterus, probably, hopefully. So we tend to use it unless there's contraindications, like the patient has a bleeding problem or, had some GI bleeding or, anything like that, we wouldn't use it. But I would try it if there's no contraindications. It's not going to hurt to anything.
So we have another question here. We're going to see if we can get to them in our last 5 minutes. Is lightning round here. Recent FET failed. Have one large fibroid, one embryo left after successful first FET in 2017. Should we try? Have one perfect daughter IVFMD patient.
So she has what was the question? She has a frozen embryo?
She has one large fibroid and one embryo left.
Well, the fibroid, again, like we mentioned before, might have to be removed, especially if it grew in any way after the pregnancy or anything like that. Your gynecologist probably can comment on it because they manage you during your pregnancy, what they think. But, you would need an SIS procedure, possibly hysteroscopy, to see what the extent of that thing is and how big it is and whether we think it's, usually, I mean, there's some people that, if it's over 4 centimeters, 5 centimeters, they should remove it. But that's got to be looked at by, your doctor, your gynecologist, and who's ever transferring your embryo as to whether it really needs to be removed, because some fibroids are not in the way at all.
Okay. All right, and we have a question about PCOS again. Age 31, high AMH of 6.3, and PCOS diagnosis. How long does it take to control the PCOS with diet and metformin?
Well, 3 months, 3 to 4 months, I would say, on average, depending, again, how motivated you are, how much weight you've got to lose, and, what your androgens are. Things like that, and what you're going to end up doing, trying to do going forward. But I would say 3 months at a minimum.
Okay, very good. And let's see here. We have a question in Spanish. I just was trying to see if I could someone does want a treatment with you, 4 years. I don't know, if you can't come. Okay, maybe, I don't see the question there, but if you can post a question.
No, I think it means somebody's trying to treat with us for 4 years, and he or she is not able to leave. Maybe they're in a different country, but you could schedule a doxy consult. Rosanna. Rosanna, is that her name? Rosanna.
Rosanna,
yes. Yeah, Rosanna, you can schedule a doxy, a computer consult, and we can talk with you over the phone, and we can help manage your problems even in another country. We do it all the time.
Shirley says that you can, I know last live she said to email them also. So if they're having questions they want to email in Spanish, then you could send that to
yeah.
You can post
But I think that's what she's saying.
Yeah. Okay.
And that's my high school. That's my high school Spanish. Let me tell you.
Very good. Good job. And it's not gonna. It's boundaries are not holding us back anymore. This is 2021. So.
Yeah. I mean, Jesus, can't remember that. No, we cannot. I see this one question. We cannot diagnose PCOS in an HSG.
Mm-hmm.
Yeah.
Okay.
Yeah.
Oh, at least Lisette is jumping in. Thank you, Lisette. She's saying that she was trying to get pregnant for 4 years and wants to get a treatment scheduled with you.
Absolutely.
Oh, okay. Thank you.
Oh, thank you, Lisette. Yes, That's what I figured you were saying, right? I was right.
Yeah, we were like half
Hey,
right.
Lisette. How are you, Lisette? Um, yeah, no, that's what I thought she was saying. So absolutely, I'd be happy to see her.
Yeah.
Either by computer consultation or in person, whatever she likes.
You guys are very busy lately. I know that. We've been hearing
Yeah,
that
but that's
you're,
okay. Hi,
you know.
Lisette.
But
I
we
know
know
Lisette. Huh?
that, yeah, Lisette's awesome. We both know you, Lisette.
Yeah, we know
Uh,
you, Lisette. Yeah.
you're our translator tonight. Thank you.
Yes, Lisette. Thank you.
And so as far, I think that we pretty much got to, oh wait, we have, of course, one little question here that popped in. Where do you like to see estradiol? Oh yeah, we did have this and we missed this one question earlier. Where do you like to see estradiol and progesterone before taking Provera?
Before taking Provera, okay. Well, estradiol levels, I mean, you could try over 50, but there should be some estrogen there. In other words, an estrogen of 20 or 10 means that you're not making estrogen, which means you're not going to respond to Provera. So somebody, for example, who's not getting their period that comes in and we do an estrogen level, and we find out it's 10, well, there's something else going on there. It's not PCOS. That means that their pituitary is not telling their ovaries to make any estrogen, so that may be some kind of pituitary problem and not PCO, so they won't respond to Provera. But somebody who is an estrogen at 60, 70, they should respond to Provera, and the progesterone level should be low, theoretically under 1, which means that they didn't ovulate. So, low progesterone, a highish estrogen would be Provera. A low estrogen would not be a candidate for Provera.
Very cool. I think we did it. We got to almost all of our questions tonight. We have a few that
Wow.
we didn't quite get to, but that was awesome. And I want to thank you for taking time out because I know this is really busy lately with all the transfers and everything you guys do.
No, we love it. We always have time for this. Once a month, it's great.
Awesome. I'm so excited.
It's
So
great.
hopefully that was helpful, guys. If you like this, we're going to repost this and to our story. Dr. Gelman will post it at Broward Fertility. Wait, what is your Instagram?
Farrar fertility expert, yeah.
Expert, that's what I thought. Okay, so
Yeah.
he'll post on his, and you guys are welcome to share it as well. We have a new YouTube channel too, and I forgot to tell you this actually, Dr. Gelman, but we've posted all of the lives to our YouTube.
Oh, wow.
So
Wow.
that is the link is in our bio. If you guys click on the bio for FLMK Wellness, it will take you to the YouTube link that has all the Q&As, the PCOS podcast. It's got yoga on there. It's got a bunch of stuff. So feel free. It doesn't look pretty, but it's on there. Okay. We're
Awesome.
working on it.
Awesome.
But everything's there. So if you guys have friends that are not on social media, that is helpful for them as well to go there.
Yep.
All right, guys. Thank you so much for joining us. Stay dry out there, and we hope to see you guys in person as well.
Yeah. Anybody that wants to schedule a computer consultation anytime, we're open to that, or in person, whatever you like. We'll be happy to see you and help you as much as we can.
Thank you guys so much, and thank you, Dr. Gelman, again.
My pleasure. See you guys soon. See you next time. Bye-bye.